Hello and welcome to the lecture on ultrasound bioeffects. Let us ruminate on the birth of medical imaging. Medical imaging was born when X-rays were discovered by William Conrad Röntgen, and he also received the Nobel Prize in Physics in 1901 for this discovery. Here in this image you can see an X-ray image of the hand of the wife of William Röntgen, and you can see her wedding ring in her ring finger. Now it turns out when you discover something new, it is unknown, and therefore the name X, in fact. The name X was given because it was an unknown kind of ray. But it is an irony that despite the unknown nature of this wave was used extensively for purposes of research, entertainment, etc., and it caused significant damage. For example, consider this quote by this gentleman, and you can guess who this gentleman is. But the quote says, "Don't talk to me about X-rays, I am afraid of them. I stopped experimenting with them 2 years ago when I came near to losing my eyesight, and Dali, my assistant, practically lost both of his arms. I am afraid of radium and polonium too, and I don't want to monkey with them." This is actually Thomas Edison. So it turns out he was researching X-rays along with his assistant Clarence Dali, who was a very famous engineer in his own right, and both of them had significant health damage because of exposure to these X-rays. So this underscores the importance of safety in medical imaging, and safety is very important because when it comes to healthcare, you may be aware that clinicians or physicians, when they complete their degree, they take the Hippocratic oath, and you may have heard the phrase "do no harm." It is actually the abbreviated version of "I will abstain from all intentional wrongdoing and harm." So even before you aspire to treat a patient, you should ensure that there is no harm incurred by the patient because of your treatment approach. So this is Hippocrates, and this is one of the earliest parchments on which this Hippocratic oath was found. So when it comes to ultrasound as well, just like X-ray, safety is paramount. Now you may have thought that ultrasound is safe. And yes, it is. Ultrasound is non-invasive, it is non-ionizing, unlike X-rays, it does not use any kind of radiation which will ionize your tissue and cause radiation damage. However, safety protocols are as important in ultrasound as in other imaging modalities. It turns out at certain exposure levels, ultrasound can cause bioeffects which can be either reversible or irreversible. When it comes to diagnostic ultrasound, largely the safety profile is well known, but there is a gamut of exposure levels which we should understand so that we can use ultrasound safely in the clinic. So I will give you an example. We know that light is safe, right? Exposure to light is safe. But if you have intense light, it can cause significant damage, or even if you have moderate intensity light but a very prolonged exposure. For example, if you stay in the sun for very long, right, it can cause some damage. So same principle applies to audible sound as well. If you keep hearing loud sounds, right, like for example, if someone works in a mine where there are frequent dynamite explosions, that can cause loss of hearing. Similarly, if someone listens to sound in a prolonged manner, for example, use of headphones where the intensity of sound may not be very high but moderate, still you can have some bioeffects which can damage your hearing. So same principles apply in diagnostic ultrasound as well. We want to avoid such bioeffects, so we are going to avoid very intense ultrasound. At the same time, we would avoid long-term exposure to ultrasound. So generally speaking, ultrasound bioeffects refer to the biological response generated in tissue due to exposure to ultrasound energy. And these bioeffects are used for therapeutic applications. There is a separate branch of ultrasound called therapeutic ultrasound, which is not the subject of this course, but we will look at it briefly. And when these bioeffects are exploited in a controlled manner, they can be clinically useful. But when it comes to imaging, we would like to avoid these bioeffects. And these bioeffects can be broadly classified as thermal effects and mechanical effects, because ultrasound interacts with tissue largely in two ways. One is through the thermal mechanism and other is through the mechanical mechanism. Now let me list down some potential bioeffects. These bioeffects include cell lysis, loss of their ability to divide, thermal necrosis, which is the destruction of the cell or tissue by heating, apoptosis, which is programmed cell death in response to ultrasound exposure. When the cells are exposed to ultrasound and they get damaged, they may undergo programmed cell death, which is called apoptosis. There can be lesioning by cavitation, more on this later. Essentially, you are causing a damage zone because of cavitation in the tissue. You can have membrane effects. For example, the cell membrane can undergo some physical changes. You can have damage to platelets in the blood. You can have hemorrhage where a vessel bursts and blood is released. You can also have vessel constriction or occlusion, essentially a blocked vessel in response to high intensity ultrasound exposure. Now, this is not a complete list, it is not an exhaustive list. There are variety of mechanisms and variety of potential damages that is possible. So, when it comes to the safety in ultrasound, the exposure levels determine safety, and you can classify them in 3 regimes. One is for diagnostic ultrasound, which includes B mode, other imaging modes and Doppler. And then there is therapy ultrasound, which may include hyperthermia, which is like increasing the temperature of your body in certain regions by a few degrees to improve healing, for example, or drug delivery in response to ultrasound. Ultrasound can serve as a stimulus to trigger drug release from some liposomes, for example. So, this has a certain regime of ultrasound exposure, and then the highest exposure regime is ultrasound surgery, where either you have high intensities such as in high intensity focused ultrasound, or high pressure amplitudes such as in histotripsy. We will discuss more on this later. Now, there is this famous principle to avoid any unwanted effects during diagnosis. Mind it, we are talking about diagnosis and not therapy. Then the principle of ALARA is followed. ALARA is the acronym for as low as reasonably achievable. So, the idea here is that the exposures used in diagnosis should be as low as reasonably achievable and not higher. So, the ALARA principle limits the escalation of ultrasound exposure, and it also avoids scans that do not produce any additional diagnostic information. So, what do I mean by that? In general, if you use a higher pressure pulse, right, it will improve the penetration depth, it will improve the contrast and signal to noise ratio. However, we are making this ultrasound image for a clinical use and not for cosmetic use. So, there is a limit to how much diagnostic information is contained in the image on the basis of these parameters. Beyond a certain signal to noise ratio, you may not need to further enhance it by increasing the pressure, right. So, the idea here is that just keep the signal to noise ratio enough to make your diagnostic call, and beyond that it does not serve a purpose and it increases the risk of adverse bioeffects. So, there are cases where it may not add significant value in the clinical context, and therefore, increasing the exposure levels is discouraged. So, I will give you an example. Here is a very impressive 3D ultrasound image, and you can also make a 4D video in which the fetus can be seen in 3 dimensions, right. And here is a standard 2-dimensional image of the fetus. So, you would probably wonder, why is still this 2D image so popular when we can make such pretty 3-dimensional images? It turns out this 4-dimensional scan or 3-dimensional scan in time actually requires more ultrasound exposure and exposure for longer times. So, therefore, it is better to avoid a 4D scan when a 2D scan will do. A 4D scan will only be recommended if the 2D scan flags something and more diagnostic information is needed, but a 4D scan should not be used casually or for cosmetic reasons. So, the idea is that the clinician will assess the risk benefit ratio. If they are using any kind of diagnostic imaging or any mode, how much is the benefit to the patient in terms of the improved diagnostic information, and what is the risk if any, and based on that they would take an informed decision keeping ALARA in mind. Now, when it comes to thermal bioeffects, the main reason for thermal bioeffects is energy deposition and heating. when you deposit energy into tissue, part of it gets absorbed, certain part of it gets reflected, refracted, etc., but some of it gets absorbed, and this is because the tissue medium has its own viscous properties. Now, typically absorption is harder to measure and attenuation is easier to measure, because you can measure attenuation straight by using the insertion loss method. Professor Carla has discussed attenuation measurement in one of her lectures. So, you can measure attenuation, and it turns out absorption is the dominant contributor to attenuation. Essentially, if you measure attenuation, you almost have absorption measurement, because absorption is the dominant contributor to the attenuation coefficient, and thus the attenuation coefficient is often used as a surrogate for absorption coefficient. Now, the temperature bioeffects depend on the temperature elevation. For example, if I take a certain tissue region and I am doing imaging, there will be heat deposition and therefore there will be temperature elevation. But if the temperature elevation is less than 1.5 degrees, then it is considered acceptable and low risk. However, if the temperature elevation is more than 4 degrees for more than 5 minutes, it can cause tissue damage, and it may be considered sensitive for regions such as the fetus, which are extraordinarily sensitive. Also, it depends on how sensitive is the tissue to heat deposition. For example, the absorption coefficients vary with tissue, right, and hence the bioeffects incurred by tissue in response to a certain amount of heat will also depend on the type of tissue. So, for example, acoustic absorption is frequency dependent, right. Recall the power law relation which was discussed by Professor Carla, and if the beam is nonlinear, right. So, if the beam has the fundamental signal as well as the harmonics, then the attenuation will increase, because these high frequency components in form of harmonics will be absorbed more. And also consider that certain tissues absorb more heat than others. For example, bone and cartilage absorb more heat and get temperature elevation very quickly. So, all these factors should be kept in mind while performing imaging. So, according to AIUM, or the American Institute of Ultrasound in Medicine, which is a professional society which provides oversight in this region, the temperature elevation, which is delta T max, should not exceed 6 minus log 10 T by 0.6, where T is the exposure time in minutes. So, essentially if you change the exposure time, if you increase the exposure time, right, then typically the temperature elevation is more. So, therefore, this formula tells you that if your exposure time is longer, you will probably have to reduce your intensity or amplitude, so that this delta T max remains lower than this value. Also, while considering thermal dose, so just analogous to dose of drugs or medicines, there is a concept of thermal dose, in which consider if you have a temperature of 43 degrees maintained for 240 minutes, it is considered lethal for the tissue. The human body can tolerate elevated temperature for short times, right. For example, we can drink high temperature drinks, we can also have fever, temperature elevation of a few degrees for a short period of time, and it is not lethal. But if a temperature exceeds 43 degrees for a long time, 240 minutes, then it is considered lethal. So, we define a concept of ultrasound dose. The thermal dose per unit time is defined as D, and it is given as an integral over time of R to the power 43 minus this T of T is the temperature profile, and this R is given as 0.25 if the temperature is lower than 43 degrees, and 0.5 if the temperature is greater than 43 degrees. Delta T is the heating period and T of T is the temperature profile. Now, this is an empirically derived formula. This is not derived from first principles, but it is useful in terms of calculating the thermal dose per unit time. Now, it turns out that these thermal effects can be used for therapy, and we will briefly discuss them, although they are not exactly imaging or diagnostics. So, the common therapeutic applications based on thermal effects are hyperthermia or diathermia, and this diathermia is very common for healing certain tissues, and high intensity focused ultrasound therapy, which is a form of ultrasound based surgery, as we will see in the next few slides. So, hyperthermia is, literally speaking, hyper is more and thermia is temperature. So, essentially it will increase the temperature locally in the body, which increases blood flow. Now, you may have experienced when you get injured, sometimes you put a hot pack on that region, or you may have put a hot water bottle on your abdomen. But ultrasound allows us to do the same thing, essentially get hyperthermia, but it can focus deeper in the body and it can reach regions which you cannot reach with a hot pack, for example. Now, the ultrasound that is used here is low intensity ultrasound, but it is used for a longer period of time, and generally it elevates the temperature by 2 to 4 degrees only, and the intensity is used at generally 1 to 2 watt per centimeter square for tens of minutes. This hyperthermia is commonly used in sports medicine for healing fractures, tendons, loosening of muscles, etc. And the frequency used is typically 1 to 3 megahertz. It is also a range of intensities which leads to cell membrane permeability. Essentially, the cell membrane becomes more permeable, which makes drug uptake more efficient. And therefore, hyperthermia has also been used with chemotherapy in cancer. First, cause hypothermia in the tissue that you want to target, and then perform chemotherapy that works better than either hyperthermia alone or chemotherapy alone. And it turns out hyperthermia also reduces cell division at the elevated temperatures, which can be used for cancer treatment in addition to radiation therapy. Now, let us discuss high intensity focused ultrasound surgery or HIFU. So, HIFU therapy uses a highly focused high intensity ultrasound beam, which can be 100 watt per centimeter square to 10,000 watt per centimeter square to thermally treat diseases. Now, here are some HIFU transducers. You can see these transducers are very large in size compared to a traditional ultrasound imaging array, and these transducers are able to generate a sharply focused beam which can have high intensities, and just by exposing for a few seconds, these transducers can actually enhance the temperature of the tissue by 60 to 70 degrees, and because of that the tissue undergoes thermal necrosis and is destroyed. So, effectively it is like destroying a certain region, just like you would excise a certain tumor. Here, without any scalpel, without cutting open the tissue, you can destroy the certain region from outside or non-invasively, which is the most interesting aspect of HIFU surgery. So, in HIFU, when you are treating the tissue with this very high intensity, sometimes the temperature elevation can be of the order of 30 to 70 degrees, and if the temperature exceeds 100 degrees, it causes boiling in tissue and bubbles are created. Now, while these bubbles can enhance heating, which is good for damaging tissue, it can also cause off target tissue damage. Essentially, if you are trying to destroy a tumor, you may also destroy some adjacent normal tissues because of this uncontrolled heating. Now, these bubbles also have an effect of shielding the target. So, let us assume that you would like to destroy this region. Assume that some bubbles are formed here. These bubbles have a high impedance mismatch, and they will also reflect the sound to a large extent. So, they will modify the ultrasound beam and they will shift the focus, because of which sometimes the distal regions are not properly ablated and you get asymmetric lesions. So, nonetheless, HIFU is being used for some applications in Western countries, in some Asian countries including India. HIFU is being used for uterine fibroid ablation. So, this is a common problem in the uterus where you can have fibrous development called fibroids, which can cause problems, but they can be treated non-invasively using HIFU. Another application is in the brain, where you can treat motor symptoms or tremors caused by this disease called essential tremor, and you can also treat the motor symptoms of Parkinson's disease. While it is not a cure for the disease itself, the disability experienced by the patient because of the motor symptoms is reduced when HIFU is used, in the brain. Many other tumors are also being treated by HIFU, and they are under research and development. And another approved application by the US FDA is treating metastasis in the bone. So, when you have a tumor originating from some other source and forming in the bone, they can be treated using HIFU to give relief to the patient. Now, HIFU is not the only ablation technique. Ablation refers to localized tissue damage, which is done for medical reasons. There are other opportunities. For example, the physician can surgically resect the tumor. There can be cryoablation performed, in which very low temperature liquid or gas is used to destroy the localized tissue. RF ablation can be performed, where electricity is used to destroy the tissue. Electrodes are placed and current is passed, which destroys the tissue locally. And then there can be laser ablation as well, but they have their own strengths and limitations. For example, cryoablation and RF ablation are not non-invasive, they are minimally invasive, and laser ablation has limited depth. So, it is used for certain applications such as in the eye, where a very clear optical window is present, but it cannot be used deep in the body, and that is where HIFU has its own advantages. Next, let us discuss mechanical bioeffects. So, just like thermal bioeffects, ultrasound also interacts with tissues in a mechanical manner. So, mechanical bioeffects can be due to interaction of pressure waves with the tissue medium, and some common mechanical bioeffects include cavitation, acoustic radiation force, and acoustic streaming. Next, let us discuss cavitation. Cavitation can be either because of contrast agent bubbles which are injected into the body for some imaging application, or it can be because of bubbles that are generated in the body itself because of ultrasound exposure. So, cavitation refers to bubble activity in response to ultrasound. Now, how can we generate bubbles in situ inside the body? This is because of ultrasound exposure, and before we try to understand how ultrasound exposure can cause bubbles to form, consider the example of soda. So, if you take a can of soda and open the can, you will see a large number of bubbles being nucleated. It turns out these bubbles were actually dissolved at high pressure in the fluid, and when you release the pressure by opening the can, bubbles are nucleated and they bubble out. Same effect happens in tissue, because ultrasound is actually a pressure wave which has phases of high pressure or compression and low pressure or rarefaction. So, in this low pressure phase, where the ultrasound causes pressure to drop, the solubility of gas in the tissue also drops and bubbles can be nucleated, right. So, that is how you would be able to generate bubbles in situ in the body, and then these bubbles would interact with the incoming ultrasound beam and cause some bioeffects. So, here is an image which shows bubble compression and expansion in response to pressure. These are actually depicting moderate amplitude oscillations, but there can also be more violent oscillations in cavitation, which we will discuss further. So, cavitating microbubbles can actually exert mechanical forces into the surrounding medium and cause tissue damage. They can also have other bioeffects, such as transiently increasing membrane permeability in the cell membranes and also promoting drug uptake through barriers in the body, such as the endothelial barrier. So, cavitation can be broadly categorized as stable cavitation and inertial cavitation. Stable cavitation is broadly defined as the oscillation of bubbles at low pressures, in which there is a repeatable bubble activity, in which the bubbles are undergoing moderate oscillations and they have a unique acoustic signature, which we will discuss in the next slide. Whereas inertial cavitation refers to the violent collapse of a bubble after a rapid growth. So, it is like an implosion of the bubble, and it also has a unique spectral signature, which we will see later. So, in stable cavitation, the ultrasound signal which is scattered exhibits a specific frequency components. It is essentially a line spectra, wherein you will have the fundamental frequency component. For example, if you are exciting the bubble at 2 megahertz, you will have a 2 megahertz peak, but you will also have a large number of f naught by 2 components. For example, 1 megahertz, which is half of f naught, You will also have 1.5 megahertz, which is called ultra harmonic, f0 by 2 is called subharmonic, and you will also have harmonic frequencies. So, this kind of line spectrum I will show you in the next slide is characteristic of stable cavitation, and in inertial cavitation you will have the growth of the bubble and the implosion, and because of this impulsive collapse, as we know impulse corresponds to broadband signal. If you take the FFT of an impulse signal in time domain, you get a broadband signal. So, the implosion of these bubbles in an impulsive manner creates a broadband spectrum. So, here are some spectral signatures. In blue, you can see the spectrum of very low amplitude oscillations, where we should not say no cavitation, but there is very weak cavitation going on. It is mostly a linear response from the bubbles at 50 kilopascal peak negative pressure. Now, as you increase the pressure, you undergo stable cavitation, in this case largely stable cavitation, although there can be a mix of stable and inertial cavitation when there are polydispersed bubble populations. So, what you see here is that you have the 2 megahertz component, but you also have a 1 megahertz component, a 1.5 megahertz component, a 4 megahertz component, which is the second harmonic, a 6 megahertz component, and so on and so forth. So, this line spectrum is characteristic of primarily stable cavitation that is going on, and then as you go to much higher pressures 4.5 megapascal, you see that the line spectrum becomes very weak, and primarily you get a broadband signal increase, which is because of impulsive bubble collapse, which is characteristic of inertial cavitation. So, now this is a very exciting development, because just by listening to the bubble activity, we can say whether primarily stable cavitation is going on or inertial cavitation is going on or both, and this listening can be performed by a cavitation detector, which is another piezoelectric transducer which is listening to the to the signals coming from these cavitating bubbles. It is only listening but not sending any pulses, that is why the word passive. So, a passive cavitation detector can actually tell you what kind of bubble activity is going on. Now, it turns out that stable cavitation and non-inertial cavitation are sometimes interchangeably used, but non-inertial cavitation is a bit broader term than stable cavitation. So, this type of cavitation produces a certain kind of bioeffects, and inertial cavitation produces separate bioeffects. Now, I will give an example of a cavitation mediated ablation therapy called histotripsy, in which a bubble cloud is formed in the focal region. Very high amplitude pulses are used which nucleate a bubble cloud, and this bubble cloud oscillation actually causes lesions in a very localized fashion, and tumors can be treated. So, a very exciting news is that just last year, probably less than 8 or 9 months ago, this technique received FDA approval for treating liver tumors. Now, the beams are very sharply focused here. So, if the tumors are large in size, then the tumor volume is actually ablated by scanning the histotripsy focus mechanically. And here is an example image where you can see you have an array of histotripsy transducers. So, each of these structures is a separate transducer, and this array can actually be controlled with each element can be controlled individually, and in the center there is an imaging probe for image guidance, because you would like to see where you are shooting your signal, your therapy pulse, and you would like to passively receive the signal from there, as well as you would like to make an image of the region so that you can target your pulse. So, here is an image of the treated region where a cavitation cloud is visible here in the ablated tumor. So, in this manner you would be able to have image guidance while simultaneously treating the tumor. So, this is an example where there is a certain region that has to be treated, which shows some echogenicity, but as you are treating it, a bubble cloud is formed, and bubbles are very good scatterers of ultrasound, as we learnt about in the ultrasound contrast agent chapter. So, these bubbles are hyperechoic here, and after that whole tissue is treated, it becomes anechoic because the tumor is completely destroyed. So, this histotripsy needs to be done under image guidance to avoid any collateral damage or off target effects, and typically it relies on the presence of hyperechoic bubble cloud in B mode images. So, here there is a hyperechoic bubble cloud, and that is where you know that the ablation is happening. So, you would have to mechanically scan so that the entire tumor is destroyed by changing the location of this hyperechoic bubble cloud. Another technique which has been in existence from late 80s, 90s is lithotripsy, which is used to break kidney stones or gallbladder stones, and this technique actually uses a high intensity focused beam which is sent onto the stone, and the stone breaks into really small parts which can then be just passed in urine. So, this technique has faster recovery time compared to regular surgery because it is largely non-invasive, and it is being used extensively in the clinic, including in India. So, let me talk about a couple of other mechanical effects. Acoustic streaming is a kind of fluid flow that is induced by the bulk motion of fluid when a tissue is treated by ultrasound, and the velocity of this fluid streaming is proportional to the acoustic power of the transducer. So, this kind of fluid motion can have some significance in terms of bioeffects because it can cause fluid mixing, it can cause convection, etc. Then there is a closely related effect called microstreaming. An oscillating bubble can cause flow patterns around it. As you can see here, this bubble is undergoing radial oscillations, and this kind of fluid flow patterns are being introduced near this bubble in response to exposure by a transducer, and this is called microstreaming. So, this microstreaming enables these bubbles to act like small micro pumps, and this fluid flow caused by these micro bubbles can generate shear stresses. So, if there are cells nearby, or let us say there are endothelial layers nearby, then it can have an effect on that, and it can also have a fluid mixing effect, and therefore the name micropump. Another prominent mechanical effect is acoustic radiation force. In acoustic radiation force, a focused ultrasound beam exerts a pushing force at a focus. So, you may be familiar with the concept of radiation pressure as employed to a comet. A comet's tail always faces away from the sun because the radiation pressure of the photons actually pushes the tail away. In a similar manner, when an ultrasound beam is fired at a tissue, there is a finite push or a force which will cause small deformations locally. So, this is called acoustic radiation force. Now, this acoustic radiation force causes transfer of momentum at the location, and this can cause some bioeffects. You will learn more about acoustic radiation force when you discuss elastography with Professor Karla. For now, I will summarize this lecture. So, we discussed why it is important to be safe in medical imaging, in diagnostics, and specifically for ultrasound. We discussed the thermal and mechanical bioeffects of ultrasound, including heating, cavitation, streaming, acoustic radiation force, the various means by which ultrasound interacts with tissue. We discussed the spectral signatures of cavitation. So, for stable cavitation we saw a line spectrum, for inertial cavitation we saw a broadband response, and we discussed a few applications including hyperthermia, HIFU surgery, histotripsy and lithotripsy. Next, we will focus on quantitative metrics for ultrasound bioeffects in the next lecture. Stay tuned till then. Thank you.